And welcome everybody. We will get started in just a few minutes. Thanks so much for being here. Just wanted to give you a couple moments to get in and get settled and make sure all the technology was working.
Why is my camera? Oh, here we go. Bree, could you say something, Bree?
I was just welcoming everybody. Thank you so much for being here. We're just letting you know we'll get started in just a couple minutes for those of you coming in. Just wanted to make sure you had a moment to get in the room, get your technology, make sure your speakers and everything were working before we get started.
Good to see you again, John. Welcome.
Hey, hello everybody.
Yeah, good to see you. How's retirement living?
Oh, I'm not retired.
Oh, I thought you were.
Retired.
Oh, okay.
Doing great work in the nonprofit space.
Yes, yes.
So I signed up for this for me personally. Is that all right? Or is this for like,
No, that's perfectly fine.
Okay.
We absolutely.
Yes.
So how are we doing on time?
We'll just give people just a couple more minutes. We'll probably go ahead and get our announcement started in just a moment. Just want to make sure everybody has a chance to get in and get settled.
We will be muting all participants at this point. You can unmute yourself if you have a question or comment, or you can also put in questions and comments into the chat box. So just so you know, we're not telling you to be quiet. We're just making it so there's no feedback for now.
Thank you, Jessica. All right, Pamela, it looks like we have a fair amount of our participants signed in here.
Okay.
You want to get started?
Yeah, let's go ahead and get started. Welcome to everyone for our 6th annual retirement series with Ent Credit Union. We've been at this since 2014 and we are excited to present it in a new venue format this year, virtual, and we hope that you will find it just as exciting and enticing as if you were sitting there live in the audience. We do not have refreshments to serve you, however, but that's something that we're going to get creative on maybe the next one. But we are the Area Agency on Aging. We are part of the Pikes Peak Area Council of Government, and we are at 14 South Chestnut Street. We are in the business of information and resources and Medicare insurance counseling and Medicaid counseling for all those 60 and over or under 60 if they have been on disability for 24 months. We publish, just so you know, we publish the Yellow Book, which is an information and assistance guide free. It's located at 14 South Chestnut in a newspaper stand. And also the Veterans Guide, the Colorado Veterans Guide for veteran benefits and Medicaid. Let me tell you just really quickly how this got started. The baby boomers have been coming in left and right, and there's about 10,000 baby boomers that change to 65 every day. And so our agency looked into the community and sought partnership with Ent Credit Union, who is a viable financial institution here in town, and they were more than happy to partner with us on this series. When you get into retirement, some of the four major things you're looking at, of course, is health, finances, purpose, and investments, or rather estate planning. And so that's what our retirement series is focused on. I think that's all I'm going to say. I know that Bree is going to talk about Ent, and then after that I will introduce Roma, your speaker for today. There will be in the retirement series, as you can see on your screen, this is the first of 4. Next week is Social Security on the 28th. October 5th is the estate planning with Skip Morgan, and then on October 9th is Sarah Qualls with Meaning and Purpose. So with that being said, welcome. And Bree, would you like to talk a little bit about Ent?
Absolutely. Thank you so much, Pamela. So I'm Bree. I'm with Ent Credit Union. Ent is the largest financial institution in Southern Colorado. But for those of you who don't know, credit unions, kind of that main credit union difference is that we're all about people helping people. We're very much for our members and our communities. So we're very excited for this to be the 6th year that we've partnered with the Area Agency on Aging to offer these retirement seminars. We really think it's valuable for people to know this information, and sometimes it's hard information to get your information on by yourself. So we're excited for the partnership. For those of you who aren't familiar with Ent, we do have over 40 locations across Colorado. We're quickly expanding in northern Colorado, but also southern Colorado has always held our roots. So we're headquartered and all local in Colorado Springs. So very proud to serve Colorado. Our true mission is truly just for people to be financially well. We want that for our members and our communities. So thank you so much again for being here, and we'll have Pamela introduce our speaker.
Thank you, Bree. So this is a little bit about Roma Costanza. She is a Colorado Springs native, and she has been assisting consumers with Medicare and all related coverages, long-term care insurance, adult Medicaid programs through the state health insurance program, which we fondly call SHIP. She's been doing that since 2000. First with the Senior Insurance Assistance, and then through the Area Agency on Aging, PPACG. The SHIP program is a federally funded program that provides unbiased education and counseling and does not endorse any specific products or companies. SHIP counselors are true consumer advocates. She is the Medicare subject matter expert and trainer for the Colorado SHIP counselors for the state of Colorado. Okay, Roma, it's all yours.
Good afternoon. Hello, everybody, and thank you for your interest in attending the Medicare Who Me or Medicare 101, everything you never wanted to know about Medicare. I appreciate your attendance, and hopefully we will learn a lot of interesting things tonight. We've got a lot of information to cover, and I will try and get through it as quickly as possible. I will pause at the end of each section so that you have an opportunity to ask questions, which you can do either by unmuting yourself, or again, you can type your question or comment into the chat box, and I will address it at the end of each section as necessary. So otherwise, I think we'll just go ahead and get started. So again, we are with the Pikes Peak Area Agency on Aging through the Pikes Peak Area Council of Governments, and the mission of the Pikes Peak Area Council of Governments is to partner with other communities and develop programs and systems that help people stay in the community for as long as possible and avoid going into facilities or assisted living. The Pikes Peak Area Council of Governments serves 3 counties in the Pikes Peak region, Park, El Paso, and Teller counties. Through the Area Agency on Aging, we are the SHIP program as well. The SHIP program stands for State Health Insurance Counseling Program, which is a federally funded program that's designed specifically to provide education and information and assistance on all things Medicare. We provide free, unbiased information on Medicare, Medicaid, long-term care. The SHIP program in El Paso County, Colorado Springs, actually serves 9 counties of Colorado, which I've listed here. Every county and every state should have access to SHIP counseling, at the very least by a toll-free statewide number. And I've listed our toll-free statewide number for Colorado as well. We are going to talk tonight about all things Medicare, including Medicare's Part A for hospitalization, Part B for all your outpatient services, and Medicare Part D for prescription drugs, as well as Advantage plans and Medicare supplements or Medigaps. Prior to this presentation, I did send an email out that included handouts that I will be referencing during the presentation. I sent it out probably within 30 minutes of this presentation starting, so you don't need to have them necessarily on hand during the presentation. They are for your reference after the presentation. So we're going to start with who runs Medicare. It is Social Security who determines eligibility for Medicare. So Social Security is the entity that determines your eligibility. They do the actual enrollments into Medicare A and B, and they issue the Medicare ID cards. Once they've done that though, they want nothing to do with Medicare. And any questions or concerns you have regarding your actual Medicare benefits and coverage, you would direct to the Centers for Medicare and Medicaid Services, or CMS. I'll simply refer to them as Medicare. CMS, where Medicare is who actually administers the program and benefits. They determine benefits and coverage. They pay the providers directly. They do all the policing and hand slapping as necessary. Social Security is available 5 days a week, Monday through Friday, 7 a.m. to 7 p.m. in all time zones via their toll-free national number. Or I've also provided our local regional office phone number and address. Obviously, they're not seeing people in person at this time, but you can call their local number, the 888 number, and get through pretty quick right now. The Centers for Medicare and Medicaid Services does not have a brick and mortar location. There is no local office for Medicare. The only way you can reach Medicare is either by calling their toll-free number or by going to their website, medicare.gov. So who can have Medicare? Well, basically, Medicare is a benefit that we earn by paying into the tax system through employer taxes. And we will become automatically eligible for Medicare at age 65, as long as you are a US citizen and you have paid into the Social Security tax system. You can also become eligible for Medicare at any age if you've been determined to be disabled by Social Security and have received at least 24 disability payments. You can also become eligible for Medicare at any age if you are diagnosed with ESRD, or end-stage renal disease, kidney failure, or Lou Gehrig's disease, ALS. And then any lawfully admitted resident alien who has resided in this country for at least 5 consecutive years is eligible to purchase Medicare. So when should you enroll in Medicare? Well, these days, most people are not going to necessarily be retired when it's time to enroll in Medicare at age 65. But when you turn 65, or within 3 months of turning 65, you enter into what they call the initial enrollment period. The initial enrollment period is a 7-month window that surrounds your 65th birthday, and it includes the 3 months prior to the month of your 65th birthday, the month of your 65th birthday, and up to 3 months after the month of your 65th birthday. That is your window of opportunity to enroll in Medicare based on turning 65. There are other times that you can enroll in Medicare, which we will talk about in much more detail as we go. Other times that you can enroll include special enrollment periods, which involve quitting work, or the general election period, which is the annual enrollment opportunity to enroll in Medicare every year. I did include in the email I sent you a handouts from Social Security that simply lists the different types of services that are available at the socialsecurity.gov website. Social Security does encourage you to create a My Social Security account. They don't require it, but they do strongly encourage it. And it can significantly help speed up the process for enrolling in Medicare online. Other things that you can do on the website or through your My Social Security account is get earnings estimators. You can find out if you have enough work history paid into the system to be entitled to Medicare, all of those kinds of things. This is what the Medicare card looks like these days. I tend to call it the red, white, and blue card. It simply has your name. It has your Medicare ID number, which these days is a random series of letters and numbers. It is no longer a Social Security number. And it will indicate when your hospital Part A and medical Part B benefits go into effect. And that is all it will ever indicate at this time. I also included in that email I sent you this handout that walks you through creating a My Medicare account. The My Medicare account and the My Social Security account are two entirely separate animals. The creating My Medicare account is a much simpler process than it is to create a My Social Security account. The My Social Security account requires a lot more security levels for obvious reasons, but the My Medicare account only takes a few minutes to set up. Again, Medicare strongly encourages you to create an account, but they do not require it. So, any questions about any of that before we get started into the individual benefits? Again, you can unmute or you can type into the chat box if you have a question. Yes, John.
Roma, it's John Carroll.
Hi.
Can I create the Medicare account anytime or only during that 7-month window?
You can create a My Medicare account at any time. You can create a My Social Security account at any time, but you do have to have a Medicare number to create that account. So you can't create the My Medicare account until you actually have a Medicare ID number.
And you can get the Medicare ID number before you get the Social
Yeah, by
Security.
enrolling in Medicare through Social Security.
Okay. Thank you.
Roma,
Yes. Yes, ma'am.
this is Joan.
Hi.
I had another question. I was helping a friend of mine sign up for Medicare online. She turned 65, but still working.
Okay.
And the Social Security said you may not have to sign up for Part A. It was a little bit confusing because I always understood if you missed signing up for Part A at age 65, you missed out.
And we are going to talk about that in much more detail. But
Okay, good. Thank you.
Because if you are still actively working, you do not need to enroll in any part of Medicare.
Okay.
And that is
That'd be good to know.
that is a common misunderstanding as far as that goes.
Okay.
About that next. So,
Okay.
questions? Let's see, I got a chat question. So how much time do you have if you are still working past age 65 to enroll? Again, if you're still working, we're going to talk about that right now. So let me answer that question here in just a sec. So now we're going to talk about the specific parts of Medicare, and we're going to start with Medicare Part A for inpatient hospitalization benefits. Before enrolling in Part A, there are some things you should consider. If you are collecting a Social Security income of any kind for any reason, whether it be retirement, early retirement, widow's benefits, whatever, disability benefits, if you are collecting an income when you become eligible for Medicare, Social Security will automatically enroll you in Medicare, and they will automatically start deducting the costs of Medicare from your income. However, excuse me, if you are still actively employed when you become eligible for Medicare and you have employer group health coverage from that employment, you can delay enrollment in Medicare in any part of Medicare until you are no longer actively working. And that again is a very common misnomer that you have to enroll in Medicare at 65. Honestly, if you are still actively working and have employer health coverage through that work, that is the only excuse Social Security will accept for not enrolling at Medicare when you first become eligible at 65. They will not accept any other reason for not penalizing you if you don't enroll at 65. For most of us, we will be eligible for Medicare Part A at no cost. And again, that is going to be based on paying taxes through employment and paying Social Security taxes. In order to be entitled to Medicare Part A at no cost when you become eligible, you'll have had to earn or work a total of 10 years and pay into the income tax system for a total of 10 years over the course of your entire lifetime to be eligible to receive Part A at no cost when you turn 65.
Okay.
That equals approximately 40 work quarters or work credits, is how Social Security calculates that. And again, that can be earned at any point over the course of your entire lifetime. So whether you earned your first 10 years of work history straight out of high school, or if you worked part-time jobs over a 30-year period, as soon as you have 10 years of work history, you will have earned your 40 quarters and Part A at no cost. If for some reason you haven't earned 40 quarters when you turn 65, you can purchase Medicare Part A, but it's not cheap. $458 per month for Part A alone. You have to purchase it. There are other ways that you might be eligible to get Part A at no cost, For example, you might be able to get that benefit through a spouse, as long as that spouse and you have been married for at least 10 years. Only Social Security would be able to tell you if you have enough work history to be entitled to Part A at no cost. They're the only ones who can tell you that. They're the ones who keep track of that. When you have Part A, Medicare Part A is, again, primarily going to be your inpatient hospital benefit. And for any inpatient medical hospital stay, Medicare Part A will cover all costs for that inpatient stay minus the deductible. This year, that deductible per admission is $1,408. That deductible is applied per admission, and that covers you for up to 60 consecutive days inpatient in the hospital. Hopefully nobody has 60 plus consecutive days in the hospital, but that is what they will cover for the first 60 days.
Yeah.
If for some reason you were in the hospital for longer than 60 days, starting at day 61, Medicare would continue to pay for your hospitalization, but they would start applying a co-insurance, meaning they would continue to pay all costs every day, except for this year, $352 per day as a co-insurance. And that would cover you up to an additional 30 days. Medicare considers 90 consecutive days in the hospital as a benefit period. If for some reason you were in the hospital for longer than 90 consecutive days, you would start going into your lifetime reserve hospital day stays. You get a total of 60 lifetime reserve days, and they start kicking in anytime you're in the hospital for longer than 90 consecutive days at a time. These days, they want to get you in and out of the hospital as quickly as possible, so hopefully none of us have to worry about being in the hospital that long. But once you've exhausted those 60 lifetime reserve days, they are exhausted, and Medicare would only cover you up to the 90 consecutive days at a time. Whether you're in the hospital as an inpatient 1 day or 90 days, that $1,408 deductible is applied per admission. It's not an annual deductible, it's a per admission deductible, so it could potentially be applied multiple times in a year. You would have to have at least 60 days from the time you were discharged from a hospital before you're readmitted to a hospital before a new benefit period would start, or before they could apply a new deductible to your inpatient stay. If you're in the hospital for a couple of weeks, you're discharged home, and then you have to be readmitted to the hospital anytime within 60 days, when you go back into the hospital, you start where you left off on the days count for that benefit period. But they also will not apply a second deductible. You're still under the first deductible. That is an important timeline to remember. You also have to be aware that that applies to skilled facility or rehab stays after a hospital discharge. Medicare Part A also covers inpatient psychiatric hospitalizations, but they do put a lifetime maximum on that benefit of 190 days over the course of your entire lifetime for any inpatient psychiatric hospitalization. There is no limit for medical hospitalizations. There are some services that Medicare will not pay while you're inpatient in the hospital. These days, pretty much all hospital rooms may come with your own individual television and telephone access, but Medicare Part A will not cover a private room unless it's deemed medically necessary by your doctor, will not cover private duty nursing or room sitters. No part of Medicare will pay for any of the first 3 pints of blood you might need under any circumstance. And it will not pay for what they consider self-administered drugs. And typically you'd run into worrying about self-administered drugs on the day of discharge. On the day of discharge, you're no longer considered inpatient, but if discharge is taking forever to get you out of there, and between the time you're scheduled to discharge and the time you actually get out of there, it comes time for you to take your maintenance medications. They may bring you that cup of pills. If you take that cup and you swallow those pills, you just self-administered medications, and they could potentially privately bill you for that because Medicare won't pay for it. The other thing you should be aware of when it comes to inpatient hospitalizations is the difference between whether you are admitted to a hospital as an inpatient or whether you are under observation in that hospital. For example, if you, for some reason, have an ambulance ride and they take you to the hospital's emergency room and you're in the emergency room for several hours and then they send you upstairs and put you in a hospital room. Just because you've been put in a hospital room does not necessarily mean you've been admitted to the hospital. You could be considered under observation in that hospital, and potentially you could be under observation for several days. That becomes important if you are discharged to a skilled facility for recovery or rehab after a hospitalization. Because, as we're going to talk about next, Medicare does cover skilled facility stays for rehab or recovery, but Medicare does require that you are inpatient in a hospital at least 3 days prior to being discharged to a rehab.
Okay.
Medicare will pay for you to be in that rehab. If you are not considered inpatient for those 3 days or longer before you're discharged to rehab, Medicare will pay none of your inpatient rehab or recovery stay in a skilled facility. If you have those 3 days or longer inpatient hospitalization before you're discharged to a rehab for a skilled facility for rehab or recovery, Medicare will pay 100% for the first 20 days of that skilled facility stay. And then starting at day 21, and again, these are consecutive day stays, starting at day 21, Medicare will continue to pay everything except for a daily coinsurance. This year, that daily coinsurance starting at day 21 is $176 per day. So Medicare will pay all or part of up to a total of 100 consecutive days at a time in a skilled facility for rehab or recovery. That 100 days at a time that they will pay for is considered, again, a benefit period. And you would have to have at least 60 days from the time you're discharged from rehab before you'd be readmitted to a rehab before you could start a new benefit period of 100 days. If you have less than that 60 days between discharge and readmission, you would simply start your benefit period where you left off when you were discharged. If for any reason you are no longer, or you're still in a skilled facility on day 101, starting at day 101, Medicare no longer cares why you're there, because all benefits will stop and Medicare will no longer pay for that inpatient stay at the skilled facility. At that point, your options to continue your care at that facility would be basically private pay, or you may have invested in long-term care insurance to help cover the cost of that continued stay, or you may qualify for the state Medicaid program to help cover the cost of that continued stay. But Medicare does put that 100-day limit on that stay per benefit period, and they assume that if you have not gotten well enough after 100 days, even if it's to go home with continued rehab at home, if you have not gotten well enough to go home after 100 days, then the likelihood of you being able to go home becomes pretty slim. So starting day 101, that stay becomes a custodial or long-term care stay. The last benefits covered under Medicare Part A are home health care and hospice, or end-of-life services. For both of those benefits, Medicare does require that a doctor certify your eligibility, both initially and then again every 60 to 90 days. Any services that are covered under those benefits are paid for by Medicare at 100%, and there are no limits to how long you can receive those kinds of services as long as the doctor continues to certify that you are eligible for those services. For home health care benefit of Medicare, what it will pay for is to have a medical person come into your home and provide rehab or provide wound care or, take care of whatever you were in the hospital for, treat you for that. What it will not pay for home care are custodial services or homemaker services. So it won't help pay for someone to come in and do light housekeeping or anything like that. It will not pay for personal care services such as helping you in and out of the shower or helping you get dressed after a hospital stay. It will only pay for medical services in the home. The hospice benefit or end-of-life benefit will pay for any and all services that are going to be designed to help make you comfortable in an end-of-life situation. So basically, you have been determined to be terminal, and it's going to pay for any medications, equipment, or services that will make you comfortable in your home in an end-of-life situation. It does not pay for room and board. So as long as you're at home, those services would be paid at 100%. But if you are in a facility or a nursing home, you would still have to worry about covering the cost of room and board. So that is basically part A in a nutshell. Any questions? I do have a question in the chat. Can my house be taken away from me as payment or reimbursement for my use of Medicare exceeding any financial limits? The answer is no. Medicare does not have financial limits to benefits. The only situation that you might have to worry about a financial limit would be Medicaid, the state low-income program. But Medicare does not have financial limits. They don't care how much money you make. They don't care how much money you don't make. They don't care what you have in the bank. Once you're entitled to these benefits and you're enrolled in these benefits, they work exactly the same way for everyone. So hopefully that answers your question. Any other questions? All right. So we'll move on to Medicare Part B. Medicare Part B is again going to be your outpatient services. Medicare Part B, again, you will automatically be enrolled in if you are already collecting a Social Security income of any kind for any reason when you become eligible, unless you call them and tell them not to. Again, if you are actively employed and covered under employer group health coverage, and that employer group health coverage can cover you and or your spouse. As long as you are actively employed and you are covering you and or your spouse under the health coverage from that employment, you can delay enrollment into Medicare, into any part of Medicare, until you stop working. It is the only excuse Social Security will accept for not penalizing you down the road for not enrolling in Medicare at 65. Medicare Part B does have a premium, and everybody has to pay a Part B premium. There are some situations where you might be required to enroll in Medicare Part B. If you want to buy a Medigap policy or Medicare supplement, you have to be enrolled in both A and B of Medicare. If you want to enroll in a Medicare Advantage plan, again, you have to be enrolled in both A and B of Medicare to do so. If you are retired military and you are currently using TRICARE benefits, when you become eligible for Medicare at 65, TRICARE absolutely requires that you enroll in A and B of Medicare, and your TRICARE standard or prime benefits would change to TRICARE for life. And that is regardless of whether or not you are still actively employed with employer group coverage. I also get a lot of questions from vets who access the VA healthcare system as their primary and only care as to whether or not they should enroll in Medicare. Because they don't intend to use it, they will continue to use the VA system. Again, you don't have to enroll in Medicare, and no part of Medicare is mandatory. Everything that we talk about tonight is optional. It is a benefit that you're entitled to enroll in, but you don't have to enroll in any of this. It's all your choice. For veterans, again, they can choose to enroll or not enroll in Medicare if they are using the VA system for all services. But if down the road they choose or decide at some point that they want to enroll in Medicare for some reason, Medicare would penalize them for that late enrollment because they're not actively employed. Active employment is the only excuse Social Security will accept for not penalizing you if you enroll later down the road. Again, and I'll keep saying this again and again, active employment with employer group health coverage covering you and or your spouse is the only excuse Social Security accepts for allowing you not to enroll in Medicare at 65 and being able to enroll when you quit working without penalty. If that is the situation, you're still working when you become eligible for Medicare, you choose not to enroll in Medicare based on that employment with employer health coverage, when you quit working, you will fall into what they call a special enrollment period. That special enrollment period is actually an extended amount of time or opportunity for you to enroll in Medicare without penalty. So if you delay enrollment in Medicare because you are employed with group coverage, when you quit working, you will have an actual 8-month window to enroll in Medicare from the time you quit working without penalty. If for any reason you don't enroll in Medicare when you first become eligible, you weren't actively employed, you simply chose not to do so. Medicare will allow you to enroll in A and B benefits anytime down the road, any year down the road during the general election period. The general election period is January 1st through March 31st each year. If you enroll during the general election period, your benefits would not start until July 1st of that year, and that's when penalties will start coming into play. The penalty is always based on the Part B premium for that year that you enroll. For 2020, the base premium is $144.60 per month from Part B benefits. And if you're collecting Social Security income, that premium would be automatically deducted from your income each month. If you're not collecting that income because you're going to wait for full retirement age or what have you, you can either elect to get billed quarterly for that premium, or you can arrange to have that premium deducted from your bank account electronically each month, which is a rather new option for Medicare or for Social Security. If you are having to deal with penalties, if you incur penalties because you didn't have that good excuse of active employment and you simply didn't enroll when you should have, the penalty is calculated by calendar years, so 12-month periods, and Medicare and Social Security will impose a 10% penalty for every full 12-month period you were without enrollment when you could have been. So for example, say you became eligible for Medicare 3 years ago, but didn't enroll for whatever reason. You now are choosing to enroll in Medicare during the general election period. Benefits will start in July. They're going to look at how many 12-month periods between the time you could have enrolled in Medicare to the time you did enroll in Medicare there were. In this example, we'll use 3 years. The penalty is 10% per year, and it accumulates every year. So you're looking at a 30% penalty. That 30% penalty will be multiplied by that year's Part B premium of this year $144.60. Whatever that comes out to will be tacked on top of the $144.60 monthly premium every month forever and ever and ever and ever. Medicare penalties never go away. So if you incur a penalty, again, if you say you continue to work, say you become eligible for Medicare in September, you continue to work until January. And then you go ahead and enroll in January because you stopped working. You're outside of your initial enrollment period. You are in a special enrollment period because you did stop working within 4 months later. So you missed your initial enrollment period. Now you have an 8-month window because you stopped working. But if you chose not to enroll in Medicare and you weren't working and you decided to enroll in Medicare during the next general enrollment period, but that was less than 12 months from the time you became eligible for Medicare. So say you became eligible in September, you enrolled in January, your benefits started in July. That's less than 12 months. And so when your benefits start in July, there will be no penalty, even though you did not enroll when you first became eligible, because there's less than 12-month period between the time you were eligible and the time you enrolled. Anything longer than 12 months will be calculated at 10% per 12-month period. The other thing you need to know is that Medicare Part B premiums are now means tested. And what that means basically is the more you have an annual income, the more you may pay in Medicare Part B premiums. The threshold for that for a single person starts at $87,000 annual income. For a single person, or a couple, $174,000 annual income. The kicker to that is that Social Security is going to make that determination as to whether or not they think you have to pay a higher Part B premium based on income on your tax records. And they're going to look at the most recent complete IRS tax record that they can access. And still, for many of us right now, it would be the 2018 income tax filing. So they're going to look at your 2018 tax filing and see if your income was at those thresholds or higher. If it was, you may get a letter in the mail that says you have to pay a higher Part B premium when you start your Medicare. If between the last complete tax filing and the time you become eligible for Medicare, you no longer have that income, you quit working, you retired, whatever, and you get that letter, you can appeal that decision based on the fact that you no longer have that high of an income. And you should appeal that decision and let them know that your income is no longer at that level so that you're not stuck paying that higher Part B premium when your income is not at that level. There are a total of 6 tiers of income, and the higher the tier, the more the Part B premium. So this is just the first threshold of income. But if your income is not at that level, when you do become eligible for Medicare, you do not have to pay that higher premium as long as you let Social Security know and fill out the appeal form. Once you have Medicare, Medicare Part B benefits are paid at an 80-20 split for most services after an initial annual deductible, which this year is $198. $198 deductible is a drop in the bucket these days compared to most deductibles. So you have to pay the first $198 each calendar year, and then most Part B services are paid at an 80-20. So what does Part B cover? Again, it is going to be all your outpatient services. So any and all types of doctor's visits, x-ray and lab work. Medicare pays for medical, surgical, and anesthesia services, and Medicare does cover medical second opinions. Covers blood starting at pint number 4, because again, no part of Medicare covers any of the first 3 pints of blood you might need. Don't ask me why. Covers all your emergency ambulance services, all your annual vaccines, the flu shot, the shingle shot, all your outpatient physical, occupational, and speech therapies, all durable medical equipment, and that's going to be your oxygen and wheelchairs and walkers. And it does have limited coverage for other services such as chiropractic, optometry, and podiatry. Services not covered by Medicare Part B are going to include routine annual physicals, routine foot care, hearing aids or the fitting of them, routine eye exams or the glasses associated with them, and even in medically necessary eye visits, Medicare does not cover refractions of the eye, where they flash the bright light and you can't see for a few hours. Currently, no part of Medicare covers dental in any way, shape, or form, although that is on the table at the federal level, and I didn't think I'd ever see that in my lifetime. Nor does it cover anything considered cosmetic. The key to Medicare coverage and benefits is medical necessity. And as long as your provider is stating to Medicare that the service you are receiving or going to receive is medically necessary, Medicare should pay for it. But it does make it absolutely your provider's responsibility to tell Medicare if a service is medically necessary. Now, Medicare has never covered anything that classifies routine. However, several years ago when preventive service benefits became the big thing, Medicare jumped on that preventive service bandwagon with both feet. And many services they used to not cover because they considered them routine are now covered because they reclassified them as preventive. Medicare does not cover annual routine physicals. Their answer to that is the Welcome to Medicare preventive visit. This is not a physical. What this preventive visit is a in-depth discussion with your medical provider, and you talk about your health history, your family's health history, your social history, your mental health history, all of those kinds of things to establish a baseline and to potentially give that provider some preventive services to recommend you take advantage of. The Welcome to Medicare preventive visit is a use it or lose it benefit. You must use it within the first 12 months of becoming enrolled in Medicare, or you lose the option. Regardless of whether or not you use that benefit, every year thereafter, you would have access to the annual wellness review, which again is just going to be an in-depth discussion with your provider about the previous year's health history, social history, etc., and give that provider an opportunity to suggest potential future preventive services that you may take advantage of. Medicare covers a huge list of preventive services, and the best way to access that list would be to go to the Medicare.gov website and click on the Medicare and You Handbook. In the Medicare and You Handbook, which you could download as a PDF, there's about a 25-page section where Medicare details and describes all the preventive services that they will cover. And starting January of this year, 2020, any preventive service Medicare covers is covered at 100%. No cost to you. But again, the best way to find that information is the Medicare and You Handbook, which you can either download as a PDF or simply view on the website, or you can call 1-800-MEDICARE and ask them to mail you a paper copy. In the preventive section detail, if there's a little blue apple symbol next to that description of the service, that indicates that it's a preventive service. In that 25-page section, they do go into detail and describe other medical services that they will cover, but most of it is going to be the preventive benefits. Okay, any questions about Medicare Part B? I do have a question in the chat box. I signed up for Medicare today and it will become effective October 1st, starting next month. My employer health insurance open enrollment starts in November 1st through the 14th for 2021, which I will decline. Will I be penalized for double dipping on the last 3 months of having my employer health insurance, including having Medicare? So basically, are you asking if you can have both? Absolutely, you can. Just because you have employer coverage does not mean you can't enroll in Medicare. Depending on the size of the employer is going to determine which coverage is primary to the other. If you needed services, who would be billed first. But as long as you're willing to pay for Medicare and you're eligible for those benefits, you can have both. And usually it will be the employer coverage that is primary and the Medicare benefit that would be secondary until the employer coverage goes away. But there is no penalizing of anything for having two insurance coverages. Hopefully that answers your question. Any other questions about Part B? No? Okay.
I think, Roma, I thought I saw another question pop up prior to that last comment.
Let me see. Okay, you're right. Thank you. So the question prior to that was, what if you don't have enough money to pay for Medicare Part B? Well, that's a very valid question. There is financial assistance programs available through the government that you may qualify for to help pay the cost of Medicare Part B, either in part or in full, and it may provide even more coverage than just the Part B premium. There are income and asset limits to qualify for that, and I will talk about that at the end of our next section a little bit more. I also have a question, is the premium the same if I have para? The answer is yes. However, if you're a para retiree, you do have the option of retirement health benefits through para, which are considered very, very good. But everybody has to pay the Part B premium. Depending on how long you've paid into the para system or whether or not you had any work history in the private sector, your Medicare or your Social Security income pension may be just enough to cover that Part B cost. And then, were there more questions? Next question. How long should I allow for Medicare to become effective if you're still working? Honestly, once you become eligible for Medicare, if you delay enrollment because of work, you can enroll in Medicare at any time after that. if you quit working. So once you are eligible for Medicare Part A, whether you continue to work or not, you can enroll in Part A at any time for any reason because it's at no cost. If you delay enrollment in Part B, you can enroll in Part B when that employment ends. So anytime that employment ends, you have up to 8 months to enroll in Part B from that point forward. So you can be enrolled in Medicare by picking up the phone and calling Social Security, and they can make it effective the first day of the following month. Or potentially they could backdate it if you're willing to backpay the premiums in some cases. The other thing you should be aware of if you do continue to work is if you are currently paying into a health savings account and you continue to work past your eligibility for Medicare, you need to be aware that you should stop contributing to a health savings account within 6 months of when you want your Medicare to go into effect. Because Social Security will backdate Part A. If you enroll later, they will backdate it 6 months. And you cannot contribute to a health savings account and be enrolled in Medicare at the same time. And the consequences are there are some not penalties, but some tax implications when you file taxes the next year. And I would encourage you to consult a tax professional to get more information about that. But that is something you should be aware of, is contributing to an HSA and being enrolled in Medicare at the same time is not allowed. So you should stop contributing to that HSA at least 6 months prior to Medicare effectiveness. You are still going to be able to use the funds in that HSA for all qualified expenses. You just can't continue to contribute to one. Any other questions? Hopefully that answered everyone's question. All right, so if there are no other questions, so now we're going to assume you have Part A and Part B, and we're going to start talking about the different kinds of health insurance options that are available to choose from on the open market for Medicare coverages. We're going to talk about both Medicare supplements or Medigap, and we're going to talk about Medicare Advantage plans, also known as Part C. But we're going to start with Medicare supplements or Medigap. Medicare supplement and Medigap are two terms for the exact same thing. And Medicare supplement coverage is private insurance policy that you purchase from a private insurance company. And it is solely and specifically designed to pay the balance that Medicare left over for Part A and Part B services after they paid their part first, period. Let me say that again. Medicare supplement policies are private policies you purchase from private insurance companies, and these policies are solely and specifically designed to pay the balance that Medicare Part A and Medicare Part B left over after they paid their part first, period. Any supplement policy you purchase must have the words Medicare supplement insurance, those 3 words in that order on the policy for it to be legitimate. All Medicare supplement insurance policies must follow all federal and state rules, laws, and regulations for your protection. The phrase Medigap comes from the thought process that it covers the gaps in your Medicare benefits or the balances that Medicare left over. Medicare supplement policies are standardized. And what that means is there is a limited number of plan levels to choose from, and those plan levels are set in stone. So regardless of who you buy a supplement from or where you buy it, all insurance companies that sell Medicare supplements are selling the same set levels of coverage, with the exception of the 3 states listed who have a couple additional levels to choose from. Even though these plans are standardized, meaning they're all selling you the same products, prices do vary from company to company based on the plan, based on the company, based on your zip code, based on your age, based on your whether you're a smoker or non-smoker, male or female, all of those kinds of things that can go into one of the convoluted formulas that insurance companies use to determine premiums. So it does pay to shop around. There are some situations where you would not need a Medicare supplement. For example, if you are already enrolled in a Medicare Advantage plan, you cannot have a Medicare Advantage plan and a Medicare supplement at the same time. You can't have both, one or the other. If you have access to TRICARE benefits or TRICARE for life, if you are a para retiree, a federal civil service retiree, if you have health benefit, retirement benefits being offered by your private employer, you may not need to worry about getting a Medicare supplement or Medicare Advantage plan, because that health benefit option from the employer or from the government may be more than adequate to cover your needs after Medicare. And I always strongly encourage you to look at any benefits you're being offered as a retirement benefit from that employer before you look at the insurance options available on the open market. For example, I can tell you that para retirees have benefits that are customized to coordinate with Medicare for their retirees, and they're enhanced, meaning they're similar to Medicare supplements or Medicare Advantage plans, but they're have enhanced benefits, which means their benefits are better than what they can purchase as a Medicare supplement or Medicare Advantage plan on the open market. So I do strongly encourage people to look at those options before they look at the open market options. That is one of the services that our office does provide, and that's one of the services of the SHIP program. The advantage of talking to a SHIP program is that the counselors through the SHIP program have been trained by Medicare and by their states, and we are able to sit down one-on-one with somebody and help them look at their specific situation and the options that are available to them, excuse me, and help them determine what options are going to work best for them overall. So we are more than happy to sit down, well, not sit down necessarily with you right now, but we're happy to talk with you either over the phone or by Zoom appointment about your individual options and help you determine what direction you want to go and how those benefits and options work, help you understand all of that and how they coordinate. When you have a Medicare supplement policy, that means you have original Medicare A and B as your primary insurance, and they will be billed and paid first. And then the supplement would simply be there as a secondary insurance to pick up any balance. Because Medicare A and B is your primary insurance, Medicare A and B is good anywhere in the United States of America and or our territories with any medical provider that will accept it or any medical facility that will accept it. That makes it much more easily traveled. So it does travel better than other options. And so it might be a much better option for people who intend to travel when they retire, for people who snowbird between Colorado and another state, because you don't have to worry about networks or that kind of thing, networks or service areas. So who can buy a Medicare supplement or Medigap policy? Anyone. Medicare supplements, Medigap policies. The only eligibility requirement is that you have both A and B of Medicare in order to be eligible to enroll in a Medicare supplement. However, there is a key to that. Medicare supplement insurance policies and insurance companies are allowed to underwrite outside of certain timeframes. The Affordable Care Act rules that say no underwriting for insurance do not apply to Medicare, because these rules were set in place way before the Affordable Care Act, and Medicare has always had a provision for people with pre-existing condition that gives you the ability to purchase this kind of coverage as long as you do so within 6 months of becoming enrolled in Medicare. It's called a guarantee issue period. So Medicare has always provided beneficiaries with a 6-month window of guarantee issue into a Medicare supplement insurance policy. As long as you purchase that policy within that first 6 months, you cannot be underwritten, meaning you cannot be turned down for any reason. If that 6-month window of guarantee issue expires and you try and purchase a supplement after that, and you have any sort of pre-existing health concern, when you apply for that supplement policy, they will look at your health history, and if they don't like what they see, they will not sell you insurance, period. It's not a matter of they'll sell you insurance but at a higher rate, or they'll sell you insurance at a lower benefit. It's an all or nothing deal. So that guarantee issue period of 6 months when you first get enrolled in Medicare can be very, very important for people who do have pre-existing health issues. That is especially important for people who are becoming eligible for Medicare based on disability through Social Security, because they're under 65 typically, and if they're receiving disability, that usually means they have a pre-existing health issue of some sort. In the state of Colorado, we do require that supplement insurance companies provide even people on disability with that 6-month window of guarantee issue. So obviously that is going to be the best time to purchase a Medicare supplement, is during the first 6 months that you have from the time you became enrolled in Medicare. Again, outside of that 6-month window, you can enroll in a Medicare supplement at any time. There is no annual enrollment period for Medicare supplements. Once you're in, you're in, but once you're out, you could be out because of underwriting. Any time outside of that guarantee issue window, you are subject to underwriting. Even if you're switching to a different plan within the same company, you could be subject to underwriting. Once that 6-month clock starts ticking, you cannot stop it. Once it expires, it's gone. Now, what we're going to talk about for the rest of this presentation is going to include a lot of special enrollment opportunities. So Medicare will always have an exception to the rule that may allow you an opportunity to get different coverage. Special enrollment periods are always going to involve some sort of involuntary loss of other coverage. Involuntary loss of other coverage could be you were working when you became eligible for Medicare, you went ahead and enrolled in Medicare and had employer coverage at the same time, and then you quit working. You didn't buy a supplement when you got Medicare because you had employer coverage. And when you quit working and lost the employer coverage through no fault of your own, it simply happens when you quit working. At that point is when your guarantee issue period would start for purchasing a Medicare supplement, because you had that other credible employer coverage. And when you lost that, that's when your guarantee issue period would start for a Medicare supplement. COBRA would also be counted as credible coverage, and loss of that would provide you with a guarantee issue into a Medicare supplement. The most common way to get guarantee issue into a Medicare supplement is through Medicare Advantage plans, and we're going to talk about that in much more detail in the next section, so I'm not going to talk about it here. But involuntary loss of other credible coverage is the key for any benefit of Medicare to be guaranteed into something, some other sort of coverage if you lose current coverage. As with all things Medicare, there are some things that are not covered by Medicare supplements: long-term care, custodial care, dental and vision, hearing aids, private duty nursing, outpatient prescription drugs, because those are covered under Part D. Basically, if it's not covered by Medicare, it is not covered by a supplement. If Medicare denies a service, the supplement will also deny that service. It is not there to pick up costs that Medicare didn't pay. It is there to pick up the balance Medicare left over after they paid first. So if it's not a benefit of Medicare, it's not a benefit of the supplement. And even if it's a benefit of Medicare, if Medicare denies a service, so will the supplement. On the other hand, as long as Medicare pays their part, a supplement is guaranteed to pay that balance. Again, in the email that I sent you before this presentation, I included a couple of handouts regarding supplements. This first handout is a one-pager, and this is the handout that describes the different levels of coverage you have to choose from as a Medicare supplement. The levels of coverage are labeled plans, whereas Medicare is parts. So Medicare has Part A and B, supplements have plans, A through N, like the alphabet, kinda. And under each plan letter designation on this chart, you'll see a benefit description. The more benefit description under the plan level means the more benefits covered after Medicare with that plan. So for example, supplement plan A, the only descriptor there is basic benefits, including the Part B coinsurance. Basic benefit Part B coinsurance is simply the 20% Medicare left over for Part B services after they paid first. That's the only benefit you're buying under supplement plan A to go with your Medicare. Supplement plan B covers the basic benefits of 20% coinsurance for Part B services and it covers your inpatient hospital Part A deductible every time you're admitted to the hospital. Plan D covers basic benefits, 20% coinsurance, covers the hospital deductible every time you're admitted, and it covers the $176 daily coinsurance for any skilled rehab facility stay longer than 20 days. So again, Medicare covers the first 20 days of skilled rehab stay at 100%. Starting at day 21, they pay everything except for $176 a day. Plan D and higher covers that $176 a day up to that 100th day. Plan D, Plan G, Plan M and N also had at the very bottom foreign travel emergency. Medicare does not pay for you for any medical needs outside of the United States of America and or our territories, and neither do the supplements. What the foreign travel emergency service is in a Medicare supplement is if you are in a foreign country, you have a medical emergency, you pay for that emergency while you're in that foreign country. But when you get back home, you can submit that bill or that receipt to the supplement, and they will tell you to bill Medicare for a denial. So then you have to turn around, bill Medicare for a denial. Once you get that, you submit both of those back to the supplement, and they will reimburse 80% of the cost of that medical emergency after a $250 deductible. So it's not travel insurance of any kind, but it could be potential reimbursement for any medical emergency in a foreign country. Plan G, which is currently considered the Cadillac of supplement coverage, covers the 20% for Part B services, covers the skilled nursing facility coinsurance, covers your hospital deductible every time you're admitted, has that foreign travel benefit, also covers what's considered Part A or Part B excess. And that is the difference between a doctor that makes you pay up front when you go for a visit and a doctor that relies on your insurance to pay them when you go for a visit. If a doctor makes you pay up front when you go for a visit with Medicare, that doctor is actually getting an extra 15% out of you above and beyond what Medicare would normally pay them. And that 15% they're getting out of you up front is called Part B excess. Plan G benefits would reimburse that extra 15% you paid up front. The rest of the plans on this chart start paying benefits at percentages, less than 100% after Medicare. K and L have maximum out of pockets because of the percentage that they pay. Plan M pays 100% for Part B, 100% for skilled care, but only 50% of your hospital deductible. And Plan N, which is becoming very, very popular, pays 100% for Part B for all services except for any and all office visits. They apply a $20 copay, or an ER visit where they apply a $50 copay and then pay everything after that. But again, skilled care and Part A deductible is covered at 100%. If this is the kind of coverage that you are looking at and that you decide to go with, I do encourage you strongly to pick your level of coverage first. Pick the plan that you are comfortable with covering you for the long haul first. Once you've decided on the level of coverage that you're comfortable with for potentially the rest of your life, then you can start shopping around. And that would be this second handout that I sent you today. This is actually last year's. I just got the updated 2021 literally last week. This handout is a multi-page handout, and it's basically the first several pages are going to go and cover everything that we've already talked about, guarantee issue and all of that kind of stuff. About halfway through that handout, you're going to start coming to these charts. At the top of each page, once you get to these charts, there's going to be an age group. Age 65, the next page says age 70, so on and so forth. It's going to have the A through N, just like this chart across the top. And then it's going to list every company licensed to sell this kind of coverage in the state of Colorado in alphabetical order, front to back of this page. And the point is that if you intersect the plan letter designation with the company, with any company, so we'll use Bankers Life. If we intersect Bankers Life with, for example, Plan G, where those two meet, if there is a number in that box, that number does represent an approximate monthly premium for that plan with that company. Having said that, these are not exact price quotes. They're in the ballpark of what you're going to pay, but they're not intended to be exact price quotes. specifically because these price quotes that are shown on the chart are price quotes for someone who turns 65 as a non-smoker and lives in an 80202 zip code. Denver does tend to pay slightly higher premiums than we do in El Paso County. So again, these prices are going to be in the ballpark, but they're not exact. What this handout is intended to do for you is help you narrow down the number of companies you would actually make contact with. So it's going to help you weed out the companies that you wouldn't want to bother with. When you're looking at Medicare supplements, again, these are standardized, meaning a Plan G is a Plan G is a Plan G, no matter who you buy it from. They're all selling the exact same Plan G, and they're all selling only the plans outlined on this chart. So it does pay to shop around when you're looking at that plan, because you'll notice as we go down this column, prices can vary significantly from one company to another for the same plan. Why is that? Because they can. Just because someone charges a higher price does not mean you're getting anything more out of them. Does not mean they're a better company, does not mean they have better coverage, does not mean you're getting better service. It just means that they calculated the premiums higher. So it does pay to shop around. Earlier in this handout, there is information about accessing the S&P and the AM Best financial websites if you want to research the financial history of any of these companies to try and determine if any of them are financially secure, if such a thing exists these days. You're welcome to do that research, but the bottom line is if you enroll in any company with a supplement and for any reason down the road that company goes belly up, they go bankrupt, whatever, and you lose that policy from that company for any reason, not your fault, it's considered involuntary loss. And Medicare would provide you with an opportunity through special enrollment to be guaranteed issue into another supplement based on that involuntary loss of current coverage. So how financially viable any of these companies are may not be as important for some people. Honestly, I don't think it's important at all because I'm not really sure I believe in financial viability these days, but it does pay to shop around, and this is going to help you narrow down the companies that you would actually contact. If any of you are just becoming eligible for Medicare or approaching age 65, I am sure you have been inundated with junk mail and emails and TV commercials. Oh my God, the TV commercials. If that is the case, and you are getting junk mail from a Medicare supplement insurance company, that may be a thicker envelope. That thicker envelope could potentially have an application in it. If it includes an application, that application would have exact premium quotes if you were to enroll with that company in any of the plans that they show. The way you can tell if it's legitimate is it should also have a chart of some sort that looks like this. So if you were to fill out that application, even though it's junk mail, if you were to fill out that application and mail it in, you would be enrolled in that company's plan at that price because you're in guarantee issue, you just became eligible for Medicare and they would have to enroll you if you submit an application. Easy as that. Otherwise, we have included their toll-free numbers so that you can call these companies directly to get some more specific pricing information. You'll notice that the prices do vary between male and female, and typically you're going to see that female pay smaller premiums than men. That's because statistically we take better care of ourselves, so we pay a slightly less premium. There's also a bunch of initials here right next to the plan companies. The key code for interpreting those initials is on the previous 2 pages. Just tells you how they determine premiums, whether it's issue age, attained age, those kinds of things, whether or not they have an application fee. Honestly, I don't recommend paying an application fee. If you can find a company that would actually be willing to do an application over the phone with you, you're just as well off. But I don't ever see a need to pay an application fee. That's totally up to you. But this is going to give you a place to start. This is going to give you a listing of everyone that's out there and help you narrow down the companies that you might actually make contact with. And that is Medicare supplements in a nutshell. Any questions about any of that? Again, hopefully everybody got the email. If you don't see it in your inbox, it might have gone to your junk mail box that has all of these handouts that I emailed you. All right, let's see if there's any questions in the chat. So because I've chosen a Medicare Advantage plan, is there an additional plan that I can purchase to pick up the extra cost or percentage that will be my responsibility, your copays, that the Advantage plan does not cover? The answer is maybe. So Medicare Advantage plans are designed specifically to be lower in premium. In exchange for that, you have out-of-pocket costs in the form of copays, and we'll talk about that in much more detail next. Traditionally, there has not been an insurance policy that you can purchase that is designed to pick up those copays for you. However, what I'm seeing come onto the market are indemnity plans that an agent may try and sell you. An indemnity plan is the kind of insurance plan that reimburses you based on whatever medical situation you had. So an indemnity plan may reimburse you a flat $100 per day for every day of hospitalization you might experience. So it may not cover all of the cost of the copay through an Advantage plan, but it may help cover some of that cost, but it's not really designed for that purpose. And then the next question is, does that 6-month window of guarantee issue, I'm assuming, apply if you take a Medicare Advantage plan initially and then switch to regular Medicare down the road? The answer is yes. So when you first become eligible for Medicare, your 6-month window of guarantee issue, that clock starts ticking. And once it starts ticking, you can't stop it. However, if you enroll in a Medicare Advantage plan, as soon as you enroll in Medicare, you are given what they call a test drive opportunity with that Advantage plan. And again, we're going to talk about that next in the Advantage plan section in detail, trust me. So hopefully I'll be able to answer that question in a few minutes. Okay, if there's no other questions, we will move on. So that was Medicare supplements or Medigap coverage. Now we're going to talk about Medicare Advantage plans, which is the other direction you could go in on the open market. Medicare Advantage plans are an entirely different animal than Medicare supplements. Medicare Advantage plans are offered by private insurance companies, but these companies contract directly with Medicare to act on Medicare's behalf and provide Medicare benefits for you. So these plans are designed to replace basically your Medicare coverage. Medicare pays them to do that. When you enroll in a Medicare Advantage plan, you will still have original A and B of Medicare. That never goes away, it just moves to the background for as long as you're enrolled in the Advantage plan and that plan is controlling those benefits. That's why sometimes Advantage plans are referred to as replacement plans. But original Medicare A and B never go away. You still have to pay your Part B premium when you enroll in an Advantage plan. You never get out of that. You still have all the rights and protections of original Medicare in a Medicare Advantage plan. You still get any and all services that original Medicare would cover through a Medicare Advantage plan. But they're called Advantage plans for a reason, and they may be able to provide benefits that are not typically covered by Medicare, such as vision and dental and hearing services, the free gym memberships, which I'm sure is the most identifiable benefit, silver sneakers. Most Medicare Advantage plans will also include Medicare Part D drug coverage at no extra cost. Medicare supplements do not include drug coverage. If you have original Medicare and a Medicare supplement, you have to purchase a Medicare drug plan in addition to those. Medicare Advantage plans will typically come with drug coverage, Part D coverage at no extra cost. There are additional eligibility requirements to enroll in an Advantage plan. The biggest one is you have to buy a plan that's available for purchase in your service area. And for all intents and purposes in Colorado, that is going to be your county of residence. So if you live in El Paso County, you must purchase a plan that's available for purchase in El Paso County only. And it's typically going to be good in El Paso County only, depending on the type of plan you get. You must have both A and B of Medicare to get the Advantage plan. And as of today, if you are already diagnosed with ESRD or end-stage renal disease, you cannot purchase a Medicare Advantage plan. And that is honestly for your protection. However, that rule may change come January. So the other thing that makes Advantage plans significantly different is that there are multiple enrollment periods for Advantage plans and Part D plans. So when can you get into an Advantage plan? Your enrollment window for enrolling in an Advantage plan is the same as for enrolling in Medicare. You get that same 7-month window of initial enrollment where you can enroll in your Advantage plan based on anticipated enrollment into Medicare anytime during that 7 months. But there are additional enrollment periods for Advantage plan and Part D plans. The annual election period, which we typically tend to call open enrollment, annual open enrollment, which happens every year, and that gives you an opportunity to either get into an Advantage or Part D plan, get out of your Advantage or Part D plan, or switch from one Advantage or Part D plan to another. Then last year, Medicare reinitiated the Medicare Advantage plan open enrollment period, which is a 3-month window, an extra 3 months you have if you're in an Advantage plan to decide if you want to keep that plan or switch to something else. And then, like I said earlier, there's always going to be special enrollment periods or opportunities for you to make a change outside of your annual enrollment periods. So the annual election period, or again, what we call open enrollment each year, happens October 15th through December 7th. Any change you make, and again, you can get into an Advantage or Part D plan, out of one, or switch from one to another between October 15th and December 7th, and any change you make would be effective January 1st. This is the longest running enrollment period for those options, and that's without restriction. The Medicare Advantage open enrollment period, which they reinitiated in 2019, if you are enrolled in an Advantage plan as of January 1st each year, you have an additional 3-month window, January 1st through March 31st, to decide if you want to stay in the Advantage plan or get out, or switch from one Advantage plan to another. If you're not enrolled in a Medicare Advantage plan as of January 1st, this enrollment period does not apply to you. And then special enrollment periods. And this is what we were going to talk about. And this is what I had questions about. Special enrollment periods, again, will always involve some sort of involuntary loss of other coverage. And the most common way that somebody is going to involuntarily lose coverage is with an Advantage plan. Because you must purchase a plan that's available for enrollment in your county of residence or service area, if you move from one county to another or from your current residence to another state, you cannot take your plan with you. And because you cannot take your plan with you and that's not your fault, it's considered involuntary loss of coverage. And when you get to the county you're moving to or the state you're moving to, you would be given an opportunity to have guarantee issue into a Medicare supplement based on that involuntary loss, or the ability to enroll in another Advantage plan, whatever is available in the area you move to. Another way that can happen is if you're enrolled in an Advantage plan, say in El Paso County, and then at the end of this year, you get a notice in the mail that says that plan is leaving the state of Colorado, and they're taking your plan with them. That again is considered involuntary loss of coverage. It wasn't your fault, and it would provide you with an opportunity to have guarantee issue into a Medicare supplement or to enroll into a different Advantage plan available in your area. The second most common way you could get special enrollment through an Advantage plan is the test drive or the trial rate. When Medicare Part D was created in 2006, and Medicare did not cover drugs prior to 2006. When Part D was created in 2006, that is about the same time that Advantage plans exploded onto the market. When that happened, there was unfortunately a lot of misinformation about what Advantage plans were and how they worked. Because of that misinformation, people were enrolling them in those plans thinking they were enrolling in something else entirely. Because of that, Medicare has created this test drive opportunity. And what that means is if you enroll in an Advantage plan, when you enroll in Medicare and you enroll in an Advantage plan from the get-go, because you enrolled in an Advantage plan first, Medicare is going to give you up to 12 months to try that plan out, to see if Advantage plans are the kind of insurance that are for you, if it's going to work for you. If at any point within that 12-month window, you decide that you don't like Advantage plans for any reason, you would be allowed to get out of that plan and still have guarantee issue into a Medicare supplement. Excuse me. So because you get 12 months to test drive the Advantage plan, this will also run alongside the 12-month of guarantee issue into a Medicare supplement. They'll run concurrently. But because you get 12 months to test drive the Advantage plan, and if you get out within that 12 months, you still have guarantee issue into a supplement, it can kind of extend your guarantee issue for up to 12 months. Your window of guarantee issue for the second 6-month period is much shorter, but it still gives you that guarantee issue opportunity. If you're in that Advantage plan for longer than 12 months, so as of that 366th day, you've exhausted your test drive and you would not have that ability to drop it and have guarantee into a supplement. But you can test drive it for up to 12 months. If Advantage plans work for you, you keep it and keep on going and everything's wonderful. And you are able to keep the Advantage plans and switch them as often during open enrollments as you want. But if you decide you don't like Advantage plans or they're really not the coverage that you're comfortable with, you need to make sure to disenroll from that plan within the 12-month window to have guarantee into the supplement. The other way you can use that is if you enroll in Medicare when you first become eligible and you enroll in a Medicare supplement from the get-go and you maintain your supplement coverage without any breaks in coverage for however long. Could be a year, could be 5 years, however. And if at any point down the road you decide you want to go ahead and try the Advantage plans, because you've maintained supplement coverage without any breaks, up until the point you enrolled in an Advantage plan during that next year's open enrollment, Medicare would again give you a 12-month test drive opportunity for that Advantage plan. If at any point during that first 12 months you decide that plan's not for you, you can drop it and have guarantee back into the supplement you had. If you try the test drive with the Advantage plan when you first get Medicare, you're guaranteed back into any supplement and any plan. But if you wait to use that test drive until down the road, you're only guaranteed back into the supplement you had that you dropped when you enrolled in the Advantage plan. So those are the two most common ways that somebody will have guarantee back into a supplement. And if you'll notice, there's a theme here, and that's getting guarantee issue into a supplement. All of these special enrollment opportunities are to provide you an opportunity to be guaranteed into a supplement. And that is simply because Medicare supplements are considered more comprehensive coverage. Basically, they're better coverage. They give you more freedom of choice and whatever. They're more expensive, but they are considered more comprehensive. Medicare Advantage plans do not underwrite. They don't care what your health issues are, and you have an annual opportunity to switch or enroll or drop Advantage plans without any restrictions every year. Again, you still have to pay your Part B premium in an Advantage plan, but many Advantage plans, especially here in El Paso County, have 0 premium in addition to that. So as long as you're paying your Part B premium, you may not have any other monthly premium for your insurance. But in exchange for that lower or no monthly premium with the Advantage plans, you will have out-of-pocket costs in the form of copays or deductibles. Again, they're required to provide you any and all Medicare covered services through the Advantage plan, but most of them will also include Part D drug coverage. You may be limited to what doctors or facilities you can go to, depending on the type of Advantage plan you enroll in. Although in an emergency or urgent care situation, you would be covered by your Advantage plan anywhere in the country. And of course, benefit and cost sharing is significantly different in an Advantage plan than it is in original Medicare. And just to make things a little more interesting, there are several different kinds of Advantage plans. There are HMOs, PPOs, fee-for-service plans, special needs plans. In order to get a complete listing of all plan choices available throughout Colorado, the best way to do that is to order a hard copy of the Medicare and You Handbook by calling 1-800-MEDICARE or going to the Medicare website and using their plan finder and getting a listing of all the plans available based on your zip code. And I'll talk about that a little bit more in a minute. There are also Medicare savings accounts, and these are all considered Advantage plans as well. We don't have any savings accounts in Colorado at this time. We do have Medicare cost plans, but those plans are being sunsetted by Medicare, meaning they're going away, and they're very expensive and they don't include drug coverage right now, so I'm not even going to talk about them. We don't currently have any demonstration or pilot programs, but we do have a PACE program in our area and along the Front Range, which is Program of All-Inclusive Care of the Elderly. And I'm going to touch briefly on each one of these types of plans. So Medicare Health Maintenance Organizations, or HMOs. If you have ever been enrolled in a Medicare HMO, you know what I mean when I say an HMO is an HMO is an HMO. They all work exactly the same way, Medicare included. And what that means is you must have a primary care provider. You are going to be limited to receiving services in the network for that HMO in your service area. You are required to get referrals to see specialists, and you may be required to get prior authorization for some services. And if you go out of network, you're paying out of pocket because your insurance nor Medicare will cover that out of network service. But all HMOs in Colorado should include Part D drug coverage. Then there are PPOs, preferred provider organizations. Preferred provider organizations have a network of providers and facilities they would prefer that you use. And if you use that network, your copays and deductibles could be lower, but you're not limited to that network of providers and facilities. And if you want to go out of network, you can. Because you're allowed to go out of network, referrals to see specialists are not required, but prior authorization for some services may be. If you go out of network, it becomes your responsibility to find the provider who's willing to take your insurance's payment, and your copay is payment in full, and you will pay a higher copay to be out of network for those services. PPOs may or may not include drug coverage. If they don't include drug coverage, then you should have a good reason why you don't need drug coverage through Part D, such as you have other credible coverage like the VA pharmacy or something, because you would not be allowed to purchase separate drug coverage if you get a PPO without drug coverage. Medicare fee-for-service plans were initially designed to have no network. This was an Advantage plan that was supposed to allow you to go anywhere in this country and see any provider who was willing to accept your plan, the plan's payment, and your copayment as payment in full without any restrictions. Unfortunately, there were agents out there selling these plans to people in areas where no provider would take them. So Medicare had to make a rule that these plans are now required to have at least one contracted provider in any county that they're available in, so that people have somewhere they can go, someone who they can see. Otherwise, you can go to any provider, again, who's willing to accept the plan's payment, and your copayment is payment in full without restriction, no prior authorizations, no referrals. The downside is, because these plans do not contract with a network of providers, any provider you find willing to take your plan can decide to take your plan on a day-by-day basis. So they can decide to take you one day and choose not to take you the next day. There's nothing that says they have to take you ever. They can make that decision on a day-by-day or case-by-case basis. And it does become your responsibility to do the legwork to find the providers that would be willing to take you. Fee-for-service plans may or may not come with drug coverage, but if they do not come with drug coverage, you would be allowed to purchase separate drug coverage so that you have a Part D benefit. Special needs plans are basically Medicare HMOs, but for specific populations, and those populations include people who are Medicare and long-term care Medicaid or full Medicaid, people who reside in certain long-term care institutions, or people who have multiple chronic health conditions. Anybody who wants additional information about these kinds of plans, you're welcome to call us, or I've listed the 1-800-MEDICARE number. Again, cost plans are being sunsetted. They were basically HMOs with more flexibility. At this time, they are very, very expensive. They do not include Part D, even though they're HMOs, and they are going away. We do have a PACE program in the Front Range area, as well as the Denver area. Basically, a PACE program is a Medicare HMO, but for a very specific population of people who are Medicare and long-term care Medicaid. And the whole point of this program is to help prevent people from going into assisted living or long-term care facilities. It's designed to help keep them in the community for as long as possible by providing extra support services through the HMO, such as medication management or transportation to medical appointments, that kind of thing. But you do have to be Medicare and long-term care Medicaid eligible. When you enroll in a Medicare Advantage plan, you are still provided all your rights and protections of Medicare. You also have additional rights to access healthcare providers with these plans. You have the right to know how these providers get paid. You have the right to very efficient, timely appeals processes regardless of the healthcare setting. You have the right to get the healthcare services you need. You have the right to receive information about your services and the plan itself in easy to understand language. And of course, you have the right to have your healthcare information kept private. If this is the kind of plan that you are looking at enrolling in, if this is what you're interested in, I simply ask that you ask yourself and the plan some questions before you enroll, such as if the plan includes prescription drug coverage, Part D, make sure that that plan covers your specific prescriptions. There are 37-ish Advantage plans throughout Colorado that include drug coverage. There are 26 or 27 Part D standalone drug plans in Colorado. Every one of those Part D benefit plans has a different list of drugs that they cover, called the formulary. So every plan has a different formulary. You want to make sure that your specific medications are on that plan's formulary. Otherwise, you will have no coverage for those medications. If you have doctors that you want to keep when you get Medicare, make sure you know whether or not those doctors participate with any Advantage plan, and if so, which ones specifically. There's nothing that says any provider has to take Medicare or has to take a Medicare Advantage plan. So your best bet is to ask the providers directly what they take. If you don't have a primary doctor that you want to keep, or you don't care if you keep your primary doctor, it's less important, but some people are very interested in keeping their current providers. In El Paso County specifically, we have 2 medical hospital networks, and some people have very, very strong opinions about one network over the other. If that is the case for you, you want to make sure you know which hospital network that plan participates with. Because if you enroll in a plan that only goes to UC Health or Memorial, but you prefer Penrose Centura, that might be a conflict. If you doctor a lot and you enroll in a plan that requires you get a referral to see that specialist or multiple specialists, you're going to have to get that referral every time you need to see a specialist. So now you're looking at 2 appointments to see that specialist and potentially 2 copays. And that might be a factor that you want to calculate into your decision. And there's just anything else that you would think is important for your personal health care. If you're not sure, ask the plan. If it's something important to you, ask the plan how that plan manages or handles that particular concern. Don't be afraid to ask questions, whether you're talking to the plan directly or whether you're talking to a broker agent trying to sell you this plan. Make sure you ask questions and make sure you understand the answers. And if for any reason they're not giving you answers that are understandable or make any sense, or they can't answer a question, think about that. And don't enroll in something that you're not 100% comfortable with. So in the email, again, that I sent earlier, I did include a couple of handouts regarding Advantage plans. The first handout is a multi-page handout, and it's basically going to touch on everything that we've just talked about. The different Advantage plan types, how they work, all of that kind of stuff. The second handout is a one-pager, and this is going to be the most useful, I hope. This handout is put together by my most wonderful volunteer. I can't believe she takes the time and energy to do this, but what she has done is she has found every Advantage plan available in El Paso County in 2020, has put them in a list alphabetically, tells you what kind of Advantage plan it is, tells you whether or not there's deductibles, premiums, gives you an idea of what each Advantage plan's copays are for primary doctors, specialist doctors, hospital stays, all that kind of stuff. Has even gone as far as to tell you what hospital network that particular plan participates with this year. That can change on an annual basis. So this is kind of a at a glance handout of all the Advantage plans available in El Paso County this year. We also have one for Teller County, but unfortunately that's the only 2 counties we do at this time. And that's primarily because those are the 2 counties in our 9-county area that have the most plans to choose from. But this is a very useful, very handy handout to have when you're considering Advantage plans, because it kind of helps you look at the costs with each different plan in a at a glance kind of thing. So very, very handy to have. Medicare Advantage plans do not change from year to year very much, but they do change. And that change could involve premiums, that change could involve deductibles and copays, that change could involve the drug formulary, could change the network of providers that you have available to choose from. So it is important that you review your coverage every year during open enrollment to make sure that you're aware of any changes and how those changes would affect you. And that's about the nutshell of Advantage plans. Any questions about any of that? No questions? Okay, then we will move on. We're almost done. We just got Part D left to cover. We'll get through this. So someone had asked if there was any help paying Medicare Part B costs, and this is it. There is a program, it's a federally funded program, it's called Medicare Savings. It does have income and asset limits to qualify for the assistance. At the highest income and asset limit, as QI1, if you qualify, what that means is the state of Colorado would pay your Part B premium so that that amount was not deducted from Social Security. They would pay it for you. And at the lowest income level, the QMB level, not only would the state pay that Part B premium, but it would also act as a Medicare supplement and pick up any and all costs and deductible that Medicare left over after they paid first. So at the lowest income level, you qualify for that level of assistance. At the highest income level, at the very least, you qualify for the state to pay that Part B premium. We do help with these applications. It is an application you have to do at a local county level. If anybody wants any additional information about these programs, please feel free to call us and we're happy to talk to you in more detail about them. All right, we're almost at the end. The last thing we're going to talk about today is Part D, D for drugs, the Medicare prescription benefit. Medicare Part D, just like with all Medicare options, is optional. The eligibility criteria is a little bit different though. In order to be eligible to enroll in a Part D plan, you only have to be enrolled in A or B of Medicare, or both. So this might become important for people who only enroll in Part A when they become eligible for Medicare and for some reason don't enroll in Part B. Because as soon as you enroll in Part A, you become eligible to enroll in Part D. And if you don't enroll in Part D and you don't have other drug coverage in place of that, when you do enroll in Part D later down the road, there could be penalties associated with that late enrollment. So Medicare Part D only requires you have A or B or both. Again, all Part D plan choices available will have a different list of drugs to choose from that they call the formulary. So they each cover a different list of drugs. If you buy a standalone Part D plan, for example, to go with original Medicare in your supplement, you can buy standalone drug coverage If you buy standalone drug coverage, you will pay a monthly premium for that coverage. However, premiums range from anywhere as low as $14 and change this year to over $100. So you will pay a premium regardless of whether or not you have a standalone Part D plan or your Part D coverage is included at no extra cost through your Advantage plan. When you go to the pharmacy, there could be copays. There will be copays and there could be deductibles. And there is financial assistance specifically for Part D benefits, which we will talk about at the end. So things to think about: if you have other credible drug coverage through an employment, through retirement health benefits, any sort of Part D coverage, the VA pharmacy is considered credible. If you have access to other credible drug coverage, and credible means as good as or better than what Part D has to offer through Medicare, then you may not necessarily need or want to enroll in a Part D plan because your coverage is as good as or better than what Medicare Part D offers. Even if you have that other credible coverage, it might be to your benefit to compare the costs that you experience through that coverage to a Part D plan to see if you would save any money through Part D, or if you're more, if it's more cost effective to stay with your current coverage. If you don't enroll in Part D and you don't have other credible drug coverage, you don't enroll simply because you don't take any drugs. Why should you enroll in a Part D plan if you don't take any drugs? Which is a perfectly viable argument. However, Medicare is still going to penalize you because you didn't have other credible coverage when you decided not to enroll in Part D, and that penalty will be applied when you do enroll, and we'll talk about how that works in a minute. For Part D, there are, again, multiple enrollment periods that you can access. Again, like the Advantage plans, you can enroll in Part D during the initial enrollment period of 7 months, the same as when you become eligible to enroll in Medicare. Excuse me. Once you're enrolled in Part D, you can take advantage of the annual election period or open enrollment each year. Again, October 15th through December 7th. You can get into, get out of, or switch from one to another Advantage plan or Part D plan. And coverage would start January 1st. Excuse me. And then, as with all other benefits that we've talked about, there could be special enrollment periods based on other involuntary loss of other coverage. The penalty for late enrollment into Medicare Part D is calculated a little bit differently than the penalty for Part B as in boy. The penalty for Part D as in drug is calculated at 1% per month for every month you could have been enrolled in a Part D plan but was not and did not have other credible coverage in place of. That 1% per month excuse me, is going to accumulate over time. And when you do enroll in a Part D plan, they're going to add up all those months. So we'll use that 3-year example again. You were eligible 3 years ago, but you didn't enroll. You didn't have other credible coverage. You're enrolling now. 3-year penalty is potentially 36% or 36 months. They're going to take that 36% penalty. They're going to multiply it by this year's national benchmark premium, or the national average Part D premium throughout the country. Whatever that multiplies out to is going to be tacked on top of whatever Part D premium you choose to pay that year. And that's not even it. So the penalty will be tacked onto the premium of whatever plan you choose to purchase. And then next year, when the benchmark national average premium is recalculated, they're going to recalculate your penalty, and they're going to multiply your 36% by that new benchmark amount. And that's what they're going to tack onto the premium of whatever plan you enroll in the next year, and so on and so forth every year. And that 36% will always be 36%, but the amount that you actually pay in that 36% penalty will change from year to year. And you may potentially change your Part D plan costs every year if you find a plan that's more cost effective from one year to the next. But again, penalties last forever. They never go away, and they're tacked on monthly. 1% per month based on a much, much lower premium comes out to a much, much lower penalty amount. But again, because it's forever, that amount does accumulate over time, and it can come out to be quite a bit of money over the rest of your lifetime. Okay, so how does Part D work? So Medicare, again, created Part D coverage in 2006. And Medicare creates the benefit. They make all the rules for the benefits. They say what's going to be covered, what's not going to be covered, how it's going to be covered, how the costs are calculated, all of that. And then they chose to let private insurance companies come in and contract with them directly to provide the drug coverage benefit to you directly. So when you enroll in a Part D plan, you are actually purchasing that coverage from a private insurer, or you're getting that coverage through your private Advantage plan insurer that's contracted with Medicare. And they're acting on Medicare's behalf to provide the coverage for you. By doing this, this gives you the freedom of choice to find a plan and gives you variety to find a plan that's going to work best for you or be most cost effective for you. But Medicare still controls how the plans work and how the coverage works. And what we have here is the basic bare bones outline of a Part D benefit. So Medicare says a Part D benefit, this is the minimal level of coverage. Medicare says Part D will have an annual deductible. This year, that deductible is $435. And what that means is when you enroll in a plan with a deductible, first time you go to the pharmacy, you are going to pay 100% full retail cost for your medication. And you will continue to pay full retail cost for your medication until you spend $435. Once you've spent $435, the next time you go to the pharmacy, you should have a much lower cost for your medication in the form of a copay. That lower cost will represent approximately 25% of retail of that cost medication. So you pay 25% of retail costs, the plan pays the other 75%. While you're paying full cost during deductible, while you're paying 25% of the cost after deductible. What Medicare and the Part D plan are doing in the background over here is they're always taking the full cost of every medication you've purchased through that plan, and they're adding it up in this column over here. And if the full retail cost in this column adds up to $4,020 this year, then you will have reached the next stage of your coverage called the coverage gap, also known as the donut hole. In the past, if someone hit the donut hole with their Part D coverage, basically when Part D started in 2006, if you hit the donut hole, you went back to paying 100% full retail cost for your drugs and still had to pay the Part D premium. Over time, between now and then, the cost that you pay when you hit the coverage gap has reduced in smaller increments until it has reached the limit of that reduction at 25%. So it went from 100% that you pay down to 25% that you pay when you hit that coverage gap or donut hole. So if you hit that $4,000 mark in retail costs, you hit the coverage gap, your costs at the pharmacy go to 25%. And you're probably sitting there thinking, well, isn't that what I was paying as my copay? Yes. However, this is the bare bones minimal level of coverage that you can get through a Part D plan in Colorado. Most plans do better than this. For example, most Part D plans these days will offer zero copay generics with your coverage. No copay, they'll pay your deductible of $435 or $0 or $1 or $2 generics or something like that. So even though this is the minimal level of coverage, with many plans, if you have a zero copay generic plan, you're not paying that 25% after deductible. But if you hit that coverage gap because the retail cost of your drugs reached that $4,000 mark, when you hit that coverage gap, you're going to go from paying zero copay generic to 25% copay generic. So that's how you would notice the change. On the other side of that coin, if you're paying a $40 copay for a brand name drug and you hit that coverage gap and the retail cost of that drug and 25% of that retail cost is only $25, your copays may actually go down on that brand name drug. Regardless of how you get there, you will probably notice some changes to your costs on your medications at the pharmacy. When you get there, Medicare and the drug plan are going to continue to add the costs to this column. But even though they took retail costs to get you to that gap, once you get to that gap, they're going to continue to add only the 25% that you're paying now at the pharmacy. And you would have to spend another $5,018 just in the 25% that you're paying at the pharmacy before you'd reach the other side of that coverage gap or donut hole. If somehow you manage to do that before the end of the calendar year, you've reached the catastrophic level of your coverage through Part D. And at that point, your cost of the pharmacy would go down to 5% or less, or $3.60 copay generics, $8.95 copay for brand name, whichever is lesser. And then come January 1st, that formula starts all over again. Again, what we see here is the minimal outline of coverage, but most Part D plans do better than that, whether it's a standalone plan or through your Advantage plan. For coverage under Part D, Medicare does require any and all plans cover at least 2 medications in every class of medication. The minimum is 2. There may be 20 different cholesterol medications in that class of medication. They're required to cover 2. They can choose to cover more, and most of them will, but the minimum is 2 in every class. There are 6 specialty classes that any Part D plan that covers these classes must cover any and all products on the market in those classes. And I typically try and pronounce these classes, but I'm not going to try and do so today, sorry. But every drug available in those classes of medication are covered by Part D. They also require that any medication you purchase through Part D coverage is approved by the FDA, that it requires a prescription from your doctor, and it is approved by the FDA for its medically intended purpose. What that means is if the doctor is trying to prescribe Viagra for your high blood pressure, Viagra was not created for that purpose, and so it would not be covered for that purpose. All Part D plans will cover drugs, biologicals, including insulin and the supplies for injecting insulin. And all plans will include brand name and generic drugs on their formularies. However, I guarantee you that if you take a brand name drug today and 6 months down the road that drug becomes available as generic, your plan will start only paying for the generic unless the doctor justifies the brand name. That's just how that's going to work. Things not covered by Part D are going to be any drugs that would have normally been covered under Part A or B of Medicare. So any medications you received while you were inpatient in the hospital are going to be covered under A. Any medications you receive in an outpatient but medical setting are going to be covered under B. That's going to include infusions, chemotherapy, dialysis stuff. Medicare Part D will not cover anything considered over the counter. Even if it requires a prescription, if it is specifically and solely used to treat anorexia or for fertility purposes or for cosmetic purposes, it will not be covered by Part D. Even if it requires a prescription, if it's used to treat cold and cough symptoms specifically and only, Robitussin is a perfect example. It's not going to be covered by Part D. And Part D will not cover most over-the-counter vitamins or supplements, or even vitamins and supplements that require a prescription, except for very few specific diseases and conditions. There is still patient assistance available from the drug makers for people who have the ability to get Medicare Part D coverage. Typically, that patient assistance is going to be available only for the very expensive brand name drugs. For example, if you see a commercial on TV for a medication, I guarantee you it's going to be very expensive, but I can also guarantee you there's probably patient assistance available to help with that cost. And you typically have to hit the coverage gap before you can apply for patient assistance. But for those really expensive medications, that is probably still something you're going to be eligible for. We have provided a couple of websites that we use, including the Medicare.gov website, to find those patient assistance programs and to look at the eligibility for people and even download and print applications for people. So for Part D coverage, again, there are over 26 Part D plans, standalone plans to choose from alone. Every one of those 26 plans has a different formulary. Every one of them has a different premium, different copays, different deductibles. The only way that you're going to be able to figure out which Part D plan is going to cover your specific medications for the best price is by going to the Medicare.gov website and using their search engine. Otherwise, you would spend days and days and days calling all of these plans, asking for the copay prices on your drugs, calculating that cost plus the premium, so on and so forth. It would take a lot of work. But Medicare has done that for us by creating a search engine. It's called the Plan Finder. It is on the Medicare.gov website, and it is the best tool to determine what plan is going to be your most cost-effective option and cover all of your medications in seconds. Not only can you put in all of your specific medications down to quantities and dosages, you can also tell it what pharmacies you prefer to use. And the end result is it will list all 26 or 27 drug plans. At the top of the list will be the plan that saves you the most money on those specific needs at the pharmacies you prefer. And at the bottom of the list, it will have the plan that would cost you the most money and give you the least amount of coverage on your specific needs. During open enrollment, basically that's all our office does. We have 5 full-time counselors, and we see literally hundreds of people in that 7-week period and help them with that plan finder to determine whether or not they are going to keep their current coverage for next year or whether or not they're going to change to a more cost-effective option for next year. And we are happy to do that every year. Obviously, this year is going to look a little bit differently because we're not going to be able to see people in person or a walk-in, but we are happy to schedule phone appointments or video appointments to do that. If possible, I'm also going to create a presentation that kind of walks you through the Part D Plan Finder search engine. So hopefully I'll be able to post that before open enrollment starts if somebody wants to try and navigate that themselves. It's really not that difficult, but sometimes it's all in the interpretation of the results, and that's where we tend to come in handy. So again, the Part D Plan Finder is not only good to look at your Part D options every year, and we do strongly encourage people to take advantage of open enrollment and look at their options, especially if you're enrolled in a standalone drug plan. Look at your options every year because drug plans, standalone drug plans will have changes more often than the drug coverage through Advantage plans. The changes include changes to premiums, copays, deductibles, drug lists. Just because a plan worked wonderfully one year for you does not mean that they're going to be as wonderful the next year because of potential changes. So we do encourage you to take advantage of open enrollment and look at your options from year to year. And you can make a change from one plan to another without restriction during open enrollment. They do not look at your health history. They don't care what you take. You just tell them what you need covered and it will tell you what plan covers that for the best price. Again, I mentioned there is financial assistance available for Part D, just like there was for Part B benefits. Financial assistance for Part D drug coverage, specifically through Social Security. So you do an application with Social Security. It's an online application. It's short, it's sweet, it's very simple. It takes less than 10 minutes to do. We are happy to help with those applications in our office. The eligibility income limits and asset limits are higher than for the Part B assistance, so more people should qualify for help with Part D costs. And if you qualify, it can reduce your premiums or eliminate them. It can significantly reduce copays and deductibles. And it may automatically allow so that you don't hit the coverage gap and your costs would not ever go up from your initial copays. Again, we are happy to help with those applications for anybody interested. And that is it. Any questions about Part D before we wrap it up? I do appreciate your patience and hanging in there for this presentation. I do have a question in the chat that says, with the Medicare Advantage, including a Part D, can I utilize the Veterans Administration benefits, including the drug coverage? The answer is yes. Because the VA and Medicare do not coordinate, you can have a Medicare Advantage plan and use that plan for services in the community. And you can also access the VA system for any services related to your VA service and medical conditions. So absolutely, you can have both. And it's one of the few options, it's one of the few benefits that allow you to have both Part D and use the VA. Absolutely. Any other questions? All right. So trusted resources for Medicare include the Medicare and You Handbook, of course, the Medicare website, and of course you can call Medicare. They are available over the phone 24 hours a day, 7 days a week, 365 days of the year. Or you're always welcome to contact your local SHIP office. That's us. And we are happy to help you with any questions, concerns, or information and education that you may be in need of. Typically, we have seen walk-ins, but obviously we're not open to the public at this time. We are available by phone, and we can schedule phone or Zoom appointments, and we're happy to do that. Or you can always call the toll-free statewide number. That number will route you to the office closest, the SHIP office closest to where you're calling from, as well as we have a statewide Spanish line. Our office also has always been the S&P program for our service area of 9 counties, which is the program that educates and assists with fraud issues for both Medicare and Medicaid. We have provided the statewide hotline as well as our local number. And we are a not-for-profit, so we are obviously always looking for volunteers. So if you are interested in doing something that is challenging and rewarding and educational, this could be a good fit for you. There's additional information about volunteering for the SHIP program on the website I've listed. Or you're welcome to contact me. We do all of our volunteer training here locally, and we're happy to talk to you about any volunteer opportunities. We do have a variety of positions that we are looking for. This presentation has been recorded, and you should get an email with a link to that recording shortly after this presentation ends. We also have a pre-recorded presentation on our PPACG website. And if you have any questions, you're welcome to email me at seniorinsure@ppacg. Those emails come directly to me. You will also receive a survey for your comments on this presentation. We are always looking for ways to improve our presentations and for suggestions on future presentations. And we appreciate any feedback you give us. And that is officially it. We are done. So again, thank you for hanging in there and for joining us tonight.
We thank everybody for participating, and please, as Roma said, fill the survey out. We look forward to getting that feedback as we go forward. And again, this was brought to you through the partnership of the PPACG, Pikes Peak Area Council of Governments, Area Agency on Aging, and the Ent Credit Union. I don't know if Bree is still online or not. I don't see her. She may have had to go. So at any rate, if you have ideas and suggestions of other seminars or presentations that would be useful to you other than the ones that are in this series, please let us know. Or if it would be worth it to break down the Medicare session and have just one on the prescription drug plans or just the supplemental plans. That information is very helpful. So again, thank you for joining us, and we will see you in the field. Please fill out the survey.
Have a great day, everyone. We'll be closing the webinar now.
Thank you, Jessica.